So we are at the hip and pelvis part 2, and I want to review a couple of things as we go in and start looking at range of motion and the muscular anatomy and how the origins and insertions impact movement. And next time we'll talk a lot about how reverse action functions through the hip, and what we typically think of as normal ranges of motion and normal muscle function in the hip are actually a little bit different. So let's look at what is normal motion. So normal flexion motion is from 0, an extended position, which, as we remember last time, that's that closed pack position of the hip, up to about 135 degrees of flexion. So 0 to 135 degrees is normal hip flexion range of motion. And then if I look at hip extension, I will typically get anywhere from 0 to 30 degrees of hip extension. And what we'll find really clinically in real life is I rarely find people that have hip extension range of motion that's past about 10 or 15 degrees. So normal range is up to 30, but a lot of that motion or that apparent 30 to plus degrees of extension is really coming from an anterior tilt and spine extension. Abduction and adduction occurring in the frontal plane is about 0 to 45 degrees of abduction and about 0 to 30 degrees of adduction. Again, end ranges of motion of abduction, adduction. Adduction, typically the other leg gets in the way. So those are a couple of components with the hip. Is other structures start getting in the way of normal hip motion. External rotation is about 0 to 45 degrees, and normal internal rotation range is to about 0 to about 30 degrees of motion. So my slide here is a little bit fuzzy, but when I'm looking at the arthrokinematics of the hip joint, remember we talked about in articulations about the concave-convex rule. So when the pelvis is fixed and the femur is the moving bone, we have a moving convex on a fixed concave. But the shape of the acetabulum and the shape of the femoral head is pretty spherical. So we don't have as much gliding and sliding that would occur with a concurrent amount of rotation. But this kind of gives us an idea of the path of the spinning that occurs. So here's my superior aspect, and here's my labrum. And so when I'm going into abduction and adduction, the path of the spinning is going to be superior and inferior. When I am moving into internal and external rotation, I'm going to have a anterior and posterior slide. When I'm going into flexion and extension, I tend to spin about an axis that stays relatively close to the middle. Now, when I kind of flip side to that and start looking at closed chain activities, I need to look at what happens in the femur when it's the fixed side. And so now the acetabulum is moving around the fixed femur, the femoral head. And that's when I'm going to now have that fixed convex with a moving concave, so the roll and the glide are going to tend to be in the same direction. So just kind of keep in mind what happens from a arthrokinematic perspective and what is occurring in the fixed convex versus the moving convex. Okay, so let's take a look at what muscles support the joint. Okay, so we're going to talk about some muscles now, and we'll initially start with the hip flexors, and the biggest, most prominent hip flexor is the psoas major. And the psoas major originates, has a big origin along the transverse processes and bodies of all the lumbar vertebrae, including the discs. There's even not shown on this picture, but there's even some fascicular attachments to the diaphragm, which we'll talk about down the road here a little bit, how the psoas can actually be an accessory breathing muscle. Its insertion is down on the lesser tubercle, lesser trochanter, of the femur. So we can see where it attaches here on the lesser trochanter. So its primary responsibility is as a hip flexor, innervated by branches off of L1 to L4, and we think of it as a primary hip flexor, but it also has an impact in reverse action on the spine, which will have a big impact on what happens when we do a sit-up or lack of core control, and the hip flexor kind of takes over and creates a variety of abnormal forces and loads through the lumbar spine. Its partner muscle is the iliacus, and the iliacus originates on the upper 2/3 of the iliac fossa, and courses down anteriorly and attaches to in the same spot on the lesser trochanter of the femur, innervated by L2, L3, and it's primarily responsible for hip flexion, so bringing the femur up. Another small muscle that we don't really see much of clinically, in fact missing in about 60% of the people, is the psoas minor, and attaches to the upper T12 and L1 spinous processes. Kind of shift around here a little bit. So it's attaching here and then traverses down and inserts on the pectineal line and the iliopectineal eminence, innervated by L1, and really primarily has a reverse action function of some trunk flexion, but it's a real weak muscle, and I think primarily plays more of a stabilizing role. Okay, let's look at rectus femoris. And rectus femoris attaches to the anterior inferior iliac crest and traverses down to attach into the superior pole of the patella, and then ultimately into the tibial tuberosity. But our interest right now is what its function is at the hip, more so than at the knee, and it's one of the quad muscles, so we'll spend a lot more time looking at this muscle when we're talking about the knee. However, it is a hip flexor, and by virtue of its attachment past the hip joint proper, its innervation is the femoral nerve, L2 through L4, and like I said, it's primarily a knee extensor, but also a hip flexor, and really is pivotal in controlling hip extension eccentrically. So we'll look at the contribution of these muscles functionally when your foot hits the ground, and we're really kind of talking about what their action is in an open chain scenario right now. But as we next week when we look at hip function and dysfunction, we'll look at how these muscles function in a more of a closed chain functional environment. Let's just come down and look at the whole group. So that was that rectus femoris. Now let's look at the sartorius. And sartorius is the longest muscle we have in our body, originating at the anterior superior iliac spine and coursing down and inserting at the tibia. The medial portion of the tibia is part of the pes anserinus attachment. Innervated by the femoral nerve, and this is also known as the talar sit muscle, in that it flexes the hip, externally rotates the hip, flexes the knee, and internally rotates the tibia. And so when we look at how people will sit with one leg crossed, their opposite knee, this is the muscle that's responsible for getting it there. So this next one we want to take a look at is the tensor fascia lata. And the tensor fascia lata originates up on the anterior superior iliac spine and posterior to the attachment of the sartorius here. It runs really quite laterally and is, for the most part, is completely enveloped by the IT band, or the iliotibial band. Innervated by superior gluteal nerve, primarily functions as an abductor and internal rotator, but really is primarily responsible for stabilization of both the knee and the hip. It's a big stabilizing muscle by virtue of its attachment along the IT band. And so it works closely with the gluteus maximus via the gluteus maximus insertion on the IT band. So there is our IT band inserting here into gluteus tubercle. So let's take a look at the adductors, and what we want to look at with the adductors is this whole group of muscles along the inside. Sometimes these are referred to as part of your growing muscles. Pectineus is the superior most, and it attaches along the pectineal line and the superior ramus of the pubis, and it inserts on the posterior surface of the femur, roughly leading a line leading from the lesser trochanter to the linea aspera. Next in line is the adductor brevis, which is deep to the pectineus and deep to the adductor longus. The adductor group, all are, with the exception of the pectineus, are innervated by the obturator nerve. And this muscle has an origin. It's kind of tough to see, but it has an origin on the superior and inferior ramus of the pubis, and inserts slightly medial to the linea aspera. And it's a rotator and adductor of the femur. And then as we continue down, we have the adductor longus. Adductor longus from the crest of the pubic symphysis, and inserting in the inserting in the linea aspera on the posterior aspect of the just medial to the insertion of the adductor magnus. So it inserts just medial to that adductor magnus. Now the adductor magnus is this long, large muscle, powerful muscle for hip extension along the longitudinal fibers, running down and attaching into Gerdy's tubercle, or excuse me, into the adductor tubercle, creating the adductor hiatus, which allows the passage for vessels and nerves. And then we also have the oblique fibers running along the entire, almost the entire length of the linea aspera. So when I look at this posterior, I can see that, well, okay, this muscle attaches not directly on the medial surface, but on the posterior surface. So there's going to be a significant contribution to rotation of the femur, and depending on the position that the femur is in at any given point will dictate what direction the rotation is occurring in. So if I continue to look a little bit more posterior, or excuse me, yeah, posterior medial, I have this muscle called the gracilis. Gracilis is originating at the pubic arch, coursing medially down and inserting into the medial tibia as part of that pes serenus. So it's going to share space there with the Sartorius and the semitendinosus, which we'll talk about here in a second. Again, innervated by the obturator nerve, and it's primarily an adductor of the thigh and helps to flex and rotate. And again, a lot of it depends on what position the hip is in. I can't stress that enough at any given point. So it's all relative to where the force vector is relative to the axis of rotation. Okay, so our hamstring group we think of as knee flexors. And which is true, they are all knee flexors based on their attachment, but they are multi-joint muscles, so they do cross the hip joint by virtue of their attachment on the ischial tuberosity. So the lateralmost hamstring is the biceps femoris. And the biceps femoris originates on the ischial tuberosity, shares a common tendon with the other two along that attachment, and inserts on the lateral surface of the fibula. So it comes down and actually has an attachment into the fibular head. There is a long head and a short head of the biceps, but we're only concerned with the hip and the long head. So this is our muscle that is responsible for hip extension and actually laterally rotates the tibia. Its muscle right next to it is the semitendinosus. And the semitendinosus, again, originating from the ischial tuberosity and then coursing down and attaching medially with the Sartorius and the gracilis. So that those three tendons form that pes serenus. And then the last hamstring is this semimembranosus, much wider, broader shaped muscle, again from the ischial tuberosity, and courses down, inserts in the posterior surface of the medial condyle of the tibia. This muscle actually, and we'll talk again when we get to the knee, has a broad attachment, and including some attachments into the meniscus. So it has some function that at the knee that helps with arthrokinematics, and is significantly important in normal knee function. So hip extension and a little bit of medial rotation, and knee flexion, which we'll get to later. And our last group is our glutes, our gluteal muscles. So let's talk about the glute maximus first. Gluteus maximus is our big hip extensor, external rotator. Huge muscle, really important. We talked about this earlier. Big supporter of what needs to happen to maintain control through the hip. Allows the trunk to function over the limbs as we're walking down the street. Originates on the posterior surface, gluteal line of the ilium, the posterior surface of the sacrum, the coccyx, the aponeurosis of the sarcospinalis ligament, the sacrotuberous ligament, and the gluteal aponeurosis, which covers the gluteus medius. Innervated by the inferior gluteal nerve, and it inserts with two insertions, one into the IT band, as I alluded to earlier, and then also into the gluteal line of the femur. Big abductor, extensor, and rotator of the hip. First layer deep to the gluteus maximus is gluteus medius. Gluteus medius attaching a little bit more superior on the gluteal surface of the ilium, and inserting into the greater trochanter of the femur, innervated by the superior gluteal nerve. Its primary function is hip abduction, but as we learn and look at how the hip and pelvis functions, its primary action is reverse action of pelvic stabilization. So it really maintains a level pelvis at loading response during gait, and so it's very important in maintaining frontal plane stability. There's also, depending on the fibers, because again we have a big wide muscle, so anterior fibers are going to provide, depending again on what position the hip is in, some hip flexion force. Posterior fibers are going to provide some hip extension force. We're going to have some internal rotation components. We'll have some external rotation components, and it's all based on fiber orientation. So we really need to keep an eye on the multi-variability of this muscle. In our last glute muscle is the glute minimus, attaching further in the inferior in the fossa, inferior to the attachment of the gluteus medius, and then inserts on the anterior portion of the greater trochanter. So this is a big internal rotator, big abductor of the femur. But again, we need to keep in mind what's the axis of rotation in the hip. What position is the hip joint in? But we typically think of the glute minimus as an open chain internal rotator. But let's think about what is it doing to maintain stability in the pelvis and move the pelvis along during gait. And then our last group of muscles that we need to talk about are our outward rotators, our lateral rotators. And superiormost is the piriformis attaching along the ventral surface of the sacrum. So if I turn my sacrum, turn my pelvis around here, I can see that I have a pretty wide attachment along the ventral surface of the sacrum, and then it inserts in the inner surface of the greater trochanter, upper border, innervated by spinal nerves L5 through S2, and it's primarily an external rotator, outward rotator. That's why we call them the 6 outward rotators. But will have some impact on hip extension, and really has an impact on stabilization, almost like the rotator cuff in the shoulder. These muscles kind of work like the rotator cuff in the hip. The superior glomerular muscle attaches along the ischial spine and inserts just inferior to the piriformis. Primarily external rotation, innervated by L5-S1, and act as a little bit of a hip extensor. The obturator internus is attaching along the inner surface of the obturator foramen, and courses along to attach inferior to the gemella superior. Again, lateral rotator, abducts the thigh when it's in a flexed position, innervated by S1, S3, and then its cousin is the obturator externus. And the obturator externus attaches along the obturator foramen, just mirroring the attachment of the internus, innervated by L3, L4, and externally rotates the thigh, stabilizes the pelvis. And really, this is a big external rotator. When I look at the way it courses, its force vector relative to the rotation vector through the hip joint. And then I have gemellus inferior, innervated by L5-S1. It kind of blends with the fibers above and below, primarily as an outward rotator. And then lastly, the quadratus femoris, nice rectangular shaped muscle, attaching a little bit inferior on the external border of the ischial tuberosity, innervated by L5-S1, and it's more of an adductor, but primarily, again, outward rotation of the femur. Again, these are all big hip stabilizing muscles. So those are muscles that we need to have a good understanding of as we move into next time the function of how the hip it works in normal motion patterns and normal activities and things that we like to do throughout the day.